Now I want to introduce Stina Klemming and Agnes Linnér, who are neonatologists, mainly working at they are working at Australian Children's Hospital, but mainly at the Danderyd site.
While you are coming up, I can mention that next year's conference of ultra-early intervention will actually have music therapy as a theme. So not only talking to infants, we believe singing is also important. So just come back next year. Okay.
Yeah, as Hugo introduced us, we're both neonatologists here at Karolinska. I'm Agnes Linnér, and this is Stina Klemming. Stina is also a NIDCAP trainee. And it's a pleasure to be here today to share with you some snapshots and stories from where we work.
And well, as Bob also said, you're the experts, and we're very honored to be here and present this for you. So these are now snapshots from reality. We know that all of you probably have units where you can take a lot of beautiful pictures, and we have now gathered some pictures from our unit where we managed to reach our goals, so to say, to give the care that we want to give. And all of what we do is actually about this triad, the patient and the family around it. But it's often in another context. It's in the context of a hospital. And we need to step very, very carefully where we put our feet, so to say, so that we don't disturb what is happening in this little triad with all our technical things. And of course, we do our ABCs. We treat the patient, we rescue the patient. Like for this girl, she was asphyxiated after a shoulder dystonia and had an APGAR score of 0 to start with. She was intubated, but here she is 45 minutes old and stabilized. And then we put her skin to skin with her mom. And this moment that the family had was a very short moment, but so important for this family. She was taken through the ward, had central catheters and so on, but she never needed hypothermia. Why do we do this? Well, we have to do it. It's actually in the Convention of the Rights of the Child that the baby should be with her parents and should not be separated against their will. And of course, it's not their will. Our philosophy of care is based on the model of synactive organization and behavioral development from Brazelton and Hagley-Salz. And many of you know this by heart, so I won't go into it. But we find NIDCAP to be a very good program. It's there from the very start to help the baby to reduce stress behaviors and increase self-regulatory behaviors, but also to guide the parents to increase their understanding of their premature child's behaviors and need, or the sick-term infant, of course. And here we have examples of the efforts of self-regulation that we all recognize. But like Martha Welsh says again and again, there's no such thing as a self-regulated baby. There are only co-regulated babies. And for this, we need the parents. We like parents to be there all the time, if it's possible. We like to do potentially stressful procedures in the parents' arms or skin to skin, if possible, to co-regulate the baby. A regulated baby who has a control over their autonomic systems and the motor system, the state system, can enable social interaction. So the self-regulation, the co-regulation, eventually leads to the parental bonding and infant attachment. It's so much easier to fall in love with a baby like this. We also very much appreciate the systems perspective, also presented by Heidi Zals, where we have the infant, the patient in the center, the parents, like the triad of the parents and the infant, the family system. There is always almost an extended family, at least siblings or grandparents and friends and so on. We have the NICU system that we've now heard Bob talk about, how different it can present itself for the babies. And the hospital systems. All our hospitals are different, and we have different challenges. And the same with the community system, and there we know that we are lucky in Sweden. Goals that we have identified when we speak about infant and family-centered developmentally supportive care is to avoid separation. We like to think of the parents as primary caregivers and include them from the very start, or never actually exclude them because they were there first. We need to support, guide and inform each parent on the basis of their needs and abilities, and that is to individualize the care, so to say, that we give to the parents. And we also like to see ourselves as facilitators of parent-infant interaction, bonding and attachment. Here we have pictures from very early after delivery with an immature baby. Both parents are there, mother's bed by the side of the baby's bed. And again, the magic triad. The closeness has to be on a level of the infant's current stability, and of course that is different, so it cannot always look the same.
So the next step, or the next circle, if you may, is the parents, and maybe especially the mothers. Most of our Karolinska NICUs are designed for couplet care, where couplet care is really different from family-centered care. Couplet care, as Bob mentioned, means where a mother and a baby are cared for in the same space. Many mothers of preterm babies need medical care themselves, and at most of our units it's possible to do this in the same space. We have large family rooms where this care can be given, looking like this, with proper hospital beds, so that the mother can quickly be shifted to the theater or intensive care if so needed. For the first couple of days, maybe it's needed for the baby to be cared for in the NICU room, where there are no permanent beds for the mother, but it's always possible to be there for a while in a bed, if needed, with the infant. So couplet care, we try not to separate at all. Even after C-section, it's possible to have the family together. In order not to separate a baby, even during transport, like from the delivery ward to the NICU, we have our in-house transportation system. We call this the NICU bridge. It's an ambulant CPAP system and a monitoring system, which has let us care for the term babies and the late preterm babies in skin to skin from the start, during transport, and during admittance to the NICU. This is a father with a late preterm baby with a transient tachypnea. But what about the smaller babies, the really preterm or really small babies? Are those something else? The babies needing medical care, lots of technical support, etc. Well, we were curious about that, and that's why doctors Björn Westrup and Nils Bergman, they took the initiative for this study, and that's currently led by the WHO, actually. It's called the Immediate Parent-Infant Skin-to-Skin Study, and Karolinska is one of the sites taking part in this study. The research question on a global level is, does immediate skin-to-skin care improve survival in low birth weight babies? At Karolinska and in Sweden, of course, we have a very low mortality, so our role in this study is mainly to look at the mechanisms of skin-to-skin. Why, if so, is skin-to-skin beneficial? Through what mechanisms? The hypothesis being that skin-to-skin care during the period of transition from the womb to extrauterine life might prevent the cascade leading to the neonatal morbidities. Many of you will think of KMC when I talk about small babies and skin-to-skin care. Well, skin-to-skin care is one of the components of KMC, but KMC and skin-to-skin care are not synonymous. I would say that KMC does not really save lives. Why? Well, according to WHO definitions, KMC should be provided to all low birth weight babies, and it should be started when stable. But when do these small babies die? Well, most of the neonatal deaths, they occur within the first 3 days of life. So many of these small preterm babies, they will never really get the opportunity. At the moment, we are conducting a pilot study, a part of this IPISTO study at the Danderyd site of Karolinska. We're looking at the stabilization of the preterm baby and the transport to the NICU from the delivery unit. So the first hour, basically, of a preterm baby's life. This is what it can look like, waiting for a 29-weeker to be born. Here's a father dressed to get his daughter in skin-to-skin. And that is the doctor on call, prepared to ventilate the baby if needed, etc. Because, of course, you cannot just put these preterm babies skin-to-skin. A lot of times they need some support, some ventilation, or at least CPAP. So always within our study we have ventilation equipment and monitoring things ready. This is an aunt consenting to take part in the study, ready to provide skin-to-skin. So after delayed cord clamping, then the baby is dried, put on the preferably mothers, but sometimes other caregiver, fathers or relatives' chests, dried, CPAP is applied, and the baby is covered. So we do all the care in skin-to-skin. The care is not different. The baby will get the care it needs, but the place will be different. Instead of a resuscitator, we use skin-to-skin. You need to pay close attention to the temperature. It's challenging to keep the baby warm, so the baby needs to be covered immediately. So stabilized with the CPAP, covered, and off to the NICU with our NICU bridge. So this is baby boy Elvin. He was born at 28 weeks. This family took part in our EPISTOS pilot study. The aunt was the skin-to-skin giver, if you can call it that. He was stabilized in skin-to-skin, provided with a peripheral line in order to start some intravenous glucose or so, without interrupting the skin-to-skin. And they report that at discharge, the boy sleeps very well with his aunt, so the perfect babysitter in the future. These are some more pictures from our study. This is a slightly more mature baby, born at 31 weeks. She's stabilized with a CPAP, skin-to-skin with the mother in the delivery room. And you can see Linda, our nurse, putting in a peripheral line. Many times it's not possible to admit the mother exactly at once. So in our pilot study, we use a lot of fathers or relatives. So after some time with the mother, the baby was shifted to the father's chest. And still, there was no hurry. We could stay in the delivery room to let the family enjoy the moment before moving to the NICU. So what are we looking at? Well, we're looking at the mechanisms of skin-to-skin, as I said. If skin-to-skin reduces mortality, how does that happen? Well, possibly early skin-to-skin care leads to an earlier onset of breastfeeding, a better nutrition and a better growth. Possibly also the hospital stay will be shorter. Maybe the baby keeps warmer in a better way. But also we're looking at the long-term neurodevelopmental outcomes through different mechanisms. One of these mechanisms could be like epigenetic modifications. Does the skin-to-skin contact change the functional genome or not?
So if parents are there taking care of their baby, what are we going to do? The role of the medical staff changes when we change our way of working, and we don't see ourselves as the doers anymore. We are the teachers and the facilitators of bonding and attachment. And to be able to do this, to teach the parents, to facilitate these processes, we need to guide the parents. And we like to quote the philosopher Kierkegaard, if one is truly to succeed in leading a person to a specific place, one must first and foremost take care to find him where he is and begin there. And here we see a staff member guiding a father to touch his baby for the very first time. And sometimes it has to really be hands-on. Eventually, parents take more and more action and responsibility in the care of their babies. And here's a father taking the temperature of a baby one day off ECMO, soon to be extubated. Lifting his baby, changing a diaper. And there are so many things that parents can do, and we like to see the parents do the baby stuff, not the medical things. Not so much touching the oxygen or things like, the really medical stuff. but there are so many baby things. And weighing the baby, for example, is one of those. So the parents do all these things with the guidance of staff members. And it's not more time consuming. It's just another way of working. Father giving a baby a bath just with the guidance of staff. Staff is just nearby. No parent would ever want to miss this opportunity of social interaction with his prematurely born baby. And we also see that the parents' presence enables a more prompt response and tuning in on the baby's signals. We teach our parents very early to feed their babies on a tube, and we use the syringes to feed the baby, and we like to feed their baby in a skin-to-skin position, or at least in their arms, to be able to read the baby's signals and adapt the pace of feeding to the baby's needs. This can also be be seen as a family gathering. Here, the family of triplets that are enjoying time together. And if we pass over to the family system, we allow siblings into the unit. And the whole family actually has to be a part of this process that this family is going through. Very proud big brother. Parents take active part during ward rounds. We plan the care for the baby together, but of course we are the ones taking the medical responsibility. But they have to get information every day about medical condition of their baby, and also they are the ones watching their baby all the time, so we can get a lot of information from the parents. And that can look different in different settings. We have here our rooms for critical care. It's for 4 babies. So just next to this father and his baby is another baby and that baby's parents. So for confidentiality, we need to put headphones with music, radio, on the other parents, not to hear what we discuss about other babies. Ward round in family rooms can look like this. So we use a laptop and we go round room for room to talk with the parents and do the day's planning and examine the babies. We win in many aspects with this concept of care. We really minimize the separation. We have early skin-to-skin care, and we have a mean skin-to-skin care of daily of 8.5 hours. I think that might be more at times, but that's what we have as a measured record. We have early parental involvement, and the parent's presence enables the tuning in on the baby. We have early bonding and attachment, and positive effects on breastfeeding. Parents feel confident caring for their child, and in that way we can discharge the family very early. It is also a very challenging and inspiring way of working. You can find real challenges in this. One is to meet the parents in their private sphere. If a family lives in a room for a long time, it can turn out to be like this. Persian New Year. To teach the parents to look at their child instead of a monitor it takes a long time. So we really need to be there to guide the parents. And we have wireless telemetry systems that allow mobile monitoring. And in the family rooms, the monitor is black. The parents don't see the saturation numbers and how high the pulse is. They look at their child and read the signals of their child. And no alarms are heard in the family rooms. The alarms are instead heard on a beeper in a nurse pocket. So we discuss the child signals with the parents. We teach them to interpret their child and not to look at specific saturation values. One of our tools in this is a scale of well-being and stress and pain that is from Astrid Lindgren, from an anesthesiologist who developed it for children and for pain, but it was further developed for newborn infants. And this we use, the nurses use this, but we also teach the parents to use it, and we discuss it with the parents. And here again, Kierkegaard fits with his very wise words. The NICU system that we heard so much about from Bob differs in all our units. And we will now show you from pictures from Danderyd, which is one of the 3 different units in Karolinska. We want somebody to be with the baby all the time. So that's why we chose to have the critical care in a NICU room of 4 beds. And then we have the family rooms where the parents are all the time. And this is also how the structure will be in our new hospital that will open late this year. In the critical room, we try to do a little private sphere for the family. And as Agnes mentioned, there is space to bring a mother's bed in here. So if the parent isn't there, there's always a staff member to look after the baby and not only look at a monitor. Also, not to disturb all the other babies in the room. We try, if we can, if there are planned procedures, to take the baby out to this procedure room where we can work without disturbing other families in like surfactant treatments or central lines and so forth. Some pictures from the ward. We think that it's very nice to have a beautiful environment. It affects not only parents, but also us working there. It doesn't have to be ugly just because it's a NICU. And Kierkegaard again.
Yes. So all these pictures look really nice, I think. Looks really peaceful and not so many babies, not at all congested. But when we've calculated a bit, Stina and I, we realized, or we think, we may be confused, but I think that 1% of all babies born in Sweden are actually cared for in the Danderyd NICU. Because at Danderyd we have 11,000 deliveries per year. And usually 1/10 of all babies born need some kind of neonatal care, long or short. So Danderyd is the largest delivery unit in Sweden, together with the units at Huddinge and Solna, where we have the other Karolinska NICUs. We have 20,000 deliveries per year. And at Danderyd we have 19 beds. How can we do that? Seems impossible. We have a level 3A NICU. We accept babies from 28 weeks and some babies who are born even earlier, where the care was started at Solna or Huddinge and they shift to Danderyd for continued care later on. But 19 beds for 11,000 deliveries is not a lot. I think one reason that this still works is that we have an early discharge program. So a large part of our patients at any given time are cared for at home, like the ones needing some gavage feeding or special attention. They can be at home with the families and still formally admitted to the ward, but at home and cared for by our home care nurses. This is our experienced home care nurse and NIDCAP observer, Kristina. She's caring for this baby at home. We're planning a more extensive follow-up program later on as a study, Stina says. So, yeah. And I think this talk doesn't go without mentioning this study, the family-centered care study by some of you in this room. I will not go into details, but through parental presence in the NICU, we could actually show that there's a reduced short-term morbidity. There's less BPD and fewer days with CPAP and oxygen. There's a shorter length of hospital stay, and there's a lower incidence of HAIs, infections. And with this system also we could see a dramatic change in infections, as I said, and a reduced cost for antibiotics. But what next? This is the beginning of a baby's life and a family's new life. What happens next when they're discharged? Well, these are, although a couple of years old, data from the EXPRESS study, a study on babies born before 27 weeks of age. We have an excellent survival. But survival isn't everything. How do they do? Well, the overall disability among Swedish children born extremely prematurely is like this. Few of them have severe morbidities. And 2/3 of the children in this cohort, they have a level of cognitive function within normal range when they start school. But parental presence in the NICUs may sound like an utopia for many of you. Well, we know that we have a very generous social security system in Sweden. We have a general parental benefit of 480 days. That's a lot. And for sick children, there's an extra 60 plus 60 days per parent and year, like if they're temporarily ill and need to stay home from school. And also if you have a preterm baby or a child with a life-threatening condition, then you get an unlimited extra number of days. So of course, that helps us. And we can only say this as an inspiration to you. And yeah. And
talking about inspiration, there is somebody who really inspired us, and many in this room. Björn has contributed greatly to the development of family-centered care in Sweden and in many other countries, and especially for Agnes and me. Here are some quotes from people in our unit. I like this one very much. To join nursing and medicine. It takes courage. And this is what Heilise Alf said when I met her in October. In Sweden, you live the NIDCAP. That's thanks to you, Björn.
thank you, Björn.